and very enormous. This. So this is my second time with AMO, and this is my second lecture. So today we'll see how cancer research has progressed in last 2 decades and what impact it has made on this dreadful disease. So if we talk about cancer care about 20 years ago, so there were about 200 fewer treatments were available that time. There were only 3 basic modalities. We all know radiation, surgery, and medical oncology or chemotherapy. Mostly we used to treat these cancers on the basis of histology, location, and size. Not much insight into the molecular oncology, not very much in-depth knowledge about the side effects of the medicine and how to manage them, how to do a personalized treatment or customized treatment to be given to these patients according to their needs, their age, their comorbidities, and so on. And of course, limited supportive care options. Still, we get the patients who are told that you have cancers, go home and just count your days, count your blessings. But nowadays it is not so. Every patient has a right to get some treatment, even if it is palliative care or pain and palliative medications. So many treatment options are there, so many palliative care procedures are there to make their life worthwhile, to alleviate their pain, to make their standard of life good. Not just cancer care is not about just chemotherapy or surgery or radiation. It is beyond that also. So if you see about this chart, cancer mortality from 1990s till 2010, mortality has gone down. This red line indicating this thing. And if you see the survivors, the number of survivors has just doubled. These are the number of survivors, and this is the mortality line which is going on continuously. So, 4 major areas where we have made an impact in the terms of treatment. New therapies are there, new imaging technologies, new machines to deliver exact precise radiation without causing any other side effects, surgical advances, more knowledge about the radical kind of surgeries and to remove more of the disease with less mutilation. Precision medicine. Each patient is unique. Molecular genetic settings are unique. To offer them some customized treatment, precision medicine is here. Of course, immunotherapy, a big thing in this era. Then in the field of prevention, we have some interventions for infection-related cancers. We'll talk about those. Cancer susceptibility genes knowledge. If we know that this patient is having BRCA-related genes or PTEN-related genes or some other syndromic things, then we know how to tackle them, what prophylactic procedures we have to do about them to decrease the risk of cancer. Certain drugs and surgical risk reduction strategies are there. Then in palliative care, quality of life aspect, better toxicity management, we know less intensive therapies are there because now we are focusing on less intensive therapies to reduce, minimize the side effects as well as preserve the efficacy of those treatments. We are more wiser in using chemotherapy. We are decreasing the number and dose of the therapies, yet keeping their efficacy intact. Palliative care integration into the armamentarium. We have some palliative care teams along with all the 3 zones of treatment like surgical, radiation, and chemotherapy. Now the area is on survivorship because the number of survivors is going up. It has almost doubled in last 2 decades. So we are now being challenged with survivorship problems. So now the new focus is on survivorship, because the patients who are cured, now they are coming up with more and more problems, growth problems, side effects, second malignancies, and so on. So late side effects are being identified. We are countering them, and surveillance strategies are being established nowadays. So just give you a glimpse, history of this cancer treatment research progress. Initially in 1965, chemotherapy cured first case, that was advanced Hodgkin's lymphoma. So that time Hodgkin's lymphoma chemotherapy contained 8 to 10 drugs, high doses, but yet it cured. And later on we got to know that those many drugs are not needed. Now we have ABVD, we have only 4 drug regimen. Sometimes now we are also coming down on the dose of bleomycin. We are making it 3 drug regimen, less number of cycles with interim PET-CT assessment and so on. In 1977, advanced testicular cancer, stage 4 testicular cancer got cured. And then 1991, major powerful anti-nausea drugs were introduced. In 2001, CML drug was introduced, which was imatinib. We still get messages. The Cancer Institute ADR has got one miracle pill to cure all cancers. We still get those WhatsApp messages. In 2006, vaccine was approved to prevent cervical cancer. So these were transformative 20 years. Now we know more about germline variation. We are into the precision medicine era. So can we move this thing, because it is hampering with the headings? Yeah. So this is the precision era. We know genetic profile, human genetic variation, germline variation, somatic mutations, and we can offer them personalized care based on these variations or mutations. So in 2000, we knew about the hallmarks of cancer, which was published. There were initially 7 hallmarks of cancer. Now they are 13. As we are progressing, we know more about the cancer genes and all. The Cancer Genome Atlas was launched in 2005. Now we know more genes, around 500 more genes which causes cancer, and we are actually developing more targeted therapies and immunotherapies, and more research is going on. In between 2010 and 14, genetic subtypes of glioblastoma, gastric, and other cancers were identified via this TCGA research team. This was on the cover of all the major magazines when this imatinib was launched. It was in 2001, May. Time magazine had this cover when this imatinib cured gastrointestinal stromal tumor or CML patients. So it was called as a miracle pill for CML patients. And still we have second generation, third generation TKIs to cure them. And nowadays we are actually talking about stopping the CML therapy after 2 or 3 years if patient is in major molecular remission. So we are progressing towards disease-free, drug-free treatment. When CML was considered to be a killer disease, that 100% mortality is there. Earlier in 7th decade, when there was no effective drug, we used to treat it with hydroxyurea only. So cancers are now classified by molecular abnormalities and site of origin. Exceptional success is there when treatment is matched to a driver mutation, but we have only few mutations which are directly linked to the cancer treatment. So first targeted drug, that is rituximab, which is against CD20 monoclonal antibody. It was launched in 1997, and NHL treatment has been revolutionized since then. Now we have more than 70% cure rate in NHL because of this drug. Trastuzumab in 1998, which is for HER2 positive breast cancer. in 2001 imatinib, and till 2016 in last from 1997 100 plus FDA approved targeted cancer drugs were approved. So this is a major breakthrough. This is a busy slide. So what is precision medicine? This is actually a patient of melanoma which was having BRAF mutation positivity. So drug against BRAF mutation, vemurafenib, was given. You can see here that this is the disease status. And after 15 weeks, complete remission was there. So this is the power of targeted medicine or molecular oncology. So we have advances in both common and rare cancers, more refined approaches, increasing and decreasing treatment aggressiveness, because now we are aggressive. We are being regressive in treatment intensities. So chemotherapy doses, how we can cut down the doses and increase the effects, more combination of drugs. So ABVD replaced MOPP for pediatric Hodgkin's lymphoma because they used to have second cancers like leukemia after 10 years and many other problems because of the radiation and all these things. So in 2004 and 5, adjuvant chemotherapy for pancreatic and lung cancer was introduced. In 2004, Oncotype DX test was introduced, and it showed that low risk early breast cancers, we can avoid chemotherapy altogether. So these type of tests and molecular oncology knowledge enabled us to give less treatment, to give more personalized treatment, to identify those patients who really don't need treatment. And those patients who really need treatment and who really need treatment for aggressive conditions. In 2007, chemo dosing was halved for low-risk neuroblastoma. Number of drugs used to treat neuroblastoma in early stages, they were halved. And pediatric cancer survivors' long-term mortality was halved. ALL now, just to give you an example, pediatric ALL has now survival rate of more than 70%, 80%. Earlier it was lethal. So as the years passed, chemotherapy is advancing, the survivals are increasing. So now on in the field of cancer detection staging, because of the better diagnostic techniques, they are being diagnosed as earlier stage because of the knowledge, because of the awareness programs. We have clearer pictures of disease spread. We have actually very good techniques to stage them, to see the treatment responses and take further actions to decrease or minimize the treatment or increase the treatment. So you can see here baseline PET-CT of a resistant GIST, which was resistant to therapy. So these were the tumors which this first line TKI was ineffective. So second line was given after 1 week only. You can see the PET, the whole disease was gone. After 2 months, complete remission, normal heart. So by this method, advanced PET-CT techniques, we can see that patient is clearly responding or not. So in other things like melanoma, immunotherapy has come, ipilimumab, pembrolizumab, and more of them, atezolizumab and other things, PD-1, PD-L1 drugs. So nowadays we have an immunotherapy for head and neck cancer, melanoma, lung cancer, kidney cancer, bladder cancer, lymphoma, and other cancers like breast cancer, lung cancer, breast cancer, urothelial cancer, and other cancers. These things are being explored, and very soon I think we'll have more immunotherapy being employed in other cancers also. So CAR T cells is a newer treatment where you can you can extract the T cells of the patients and treat them and then reinfuse them. So they are reprogrammed and they attack the cancer cells, and in T cell leukemia or B cell leukemia, these CAR T cells are doing wonders. In refractory relapsed ALL are being cured. The CR rates are exceptionally well, 60%, 50% complete remission in those leukemias who were relapsed and there was no hope left. So some of these cancers are by infectious disease, and as you go from the developed countries to third world countries, the number of cancers, percentage of numbers cancers caused by infectious disease increases. In Africa, it is about 33%. In Europe, it is 7%, and global it is 16%. So which are the cancers? So we have cervical cancer, anal cancer, vulvar vaginal cancer, penile cancer, pharyngeal cancer. These are all caused by human papilloma virus. So in 1999, we had this DNA test approved. Vaccine was approved in 2006. And now we have acetic acid or vinegar screening, which is PHC based screening test for cervical cancer, which is being employed. And now we are training primary healthcare center doctors to screen cervical cancer patients in their PHC. Hepatitis B has 80% vaccine coverage. It is a major breakthrough because most of these HCCs are because of hepatitis B and hepatitis C. So on hepatitis C, now curative therapies are there. So in both these areas, we are gaining more experience. In supportive care, we have these injections which are actually after myelosuppression are being treated by these filgrastim injections which were introduced in 1999. So we have less side effects. We know which are the patients who are actually akin to more myelosuppression, like multiple comorbidities, advanced age. These patients, we prophylactically give them these things. So pain management, now we have advanced procedures like nerve block. Thanks to our pain palliation team, anesthesia people are giving nerve blocks, celiac ganglion blocks, and other blocks also. More painkillers like fentanyl patches, buprenorphine patches, and more these things are available now. And early palliation, when patient is asymptomatic, is eating better, nutrition is being taken care of, survival automatically improves. So now we have 32 or more million 5-year cancer survivors worldwide. So we need to see about their cardiac health, their surveillance, psychosocial needs, obesity problems, disparities, sexual health, and coordination. So if we keep pressing forwards, imagine where will we be in another 20 years. So with this, I rest my case.